Okay, welcome everyone. Good morning. Try to make it a little bit louder. So, yeah, now I can hear myself. Okay, welcome, morning. Today we will cover the last part of the Hospitals in Detail lecture, and we'll start with the appointment planning. Just one announcement I uploaded, because last time we had this discussion about Lauterbach's reform, and I found some video that criticizes a little bit the idea of that and the consequences of it. Unfortunately, it's in German. I couldn't find anything in English, but hopefully you can, just if you want to be informed. I uploaded it to Elias under the additional material file. Okay, so if you are interested in that. Okay, any questions concerning the lecture or the exercise? Okay, then let's start with capacity planning in hospitals. You can see everything? Okay. So the most important thing, not one of the most important things, let's say, is the number of beds. So if you are ill and you go to a hospital, it doesn't matter if there are enough nurses, enough doctors, enough medical supplies. If they don't have a free bed for you, then they won't admit you. Okay, so beds are really critical in hospitals. And this is why often we have some kind of fancy approaches to determine the required number of beds. In many federal states, in Germany at least, we use a very simple formula to decide on the number of beds that are needed for a particular year. So, let me try to use that one again. So, okay, so capital BI is the number of beds for a particular specialty. So let's say the surgery ward or the cardiological ward, something like this. Okay, and the formula is used particularly in Germany, which is very simple but also very intuitive. So it's basically the population size in the catchment area. Maybe you remember that the catchment area was the so-called market area, so patients that can come to your hospital. So this is your demand area, okay, that you have to serve. For instance, this is the entire population of Baden-Württemberg, for instance, for the Karlsruhe hospital in the public one. The HI, this is the average number of cases or patients or stays in a hospital in specialty I per year. Okay, so that is how many patients or how many of this populations are really coming to your hospital in this particular specialty. Okay, so the average number basically. And multiplied by VI, so this is the average length of stay in specialty I. Okay, and so this is the product here divided by the capacity utilization in specialty I. So what we know is that I told you last time, it was shown that, let's say, 70% utilization rate is perfect, because then you can react to emergency cases better, so that you have still some kind of buffer. Okay, so you have empty beds that you can use for incoming urgent patients. Okay. Okay, so this is still used in Germany because it's, as I said, very intuitive, explainable to the staff member. But of course, we have here different things that are not considered. So, if, for instance, there's no evaluation if this is a good formula or not. So, how do we perform in comparison to the last year, for instance? This is not given here. And of course, we have several other disadvantages with this formula. We will come to that a bit later. Okay, there's also, for instance, no time frame, right? So, okay. So let's have a look at an example. So the Hill-Burton formula is used, for instance, to understand how many beds, surgery beds, are needed in North Rhine-Westphalia. Let's say we have a population size of 18 million. However, only 5% of this population were in the surgical ward last year. Okay, this is about 900,000. Okay, they needed the surgery, for instance, 2018 or something like this. And then we have treatment days or stays for all surgical cases. So these 900,000 patients that needed a surgery, they stayed in total 8 million days last year. Okay, and the utilization rate was 82.5%. Okay. So what is the solution? First of all, we of course need the number of surgical cases in this year, so the population 18 million multiplied by the 5%. So as I said, 900,000 patients needed surgery last year. How to determine the LOS, length of stay, because we need, for the Hill-Burton formula, we need VI, so the average length of stay. How to determine that? It's basically the days of treatment, which is 8 million in total, divided by the number of cases. So that means, on average, each surgical patient stayed roughly 8-9 days in hospital last year. Okay, so you know the average length of stay. And then, with these numbers, we can then compute and determine the number of beds needed in the surgical ward, which is about roughly 27,000 beds. Okay, so this seems to be a lot. Of course, no hospital has so many beds available, but for this particular example, 27,000 beds would be needed. Okay, yeah, or 26,571. Okay. Okay, so some ideas what could be criticized. Why is this, let's say, too simple formula? Yeah, please. Cancelled out. Yeah, good. Someone else? What could be criticized here? So what is not included in this formula? Some ideas. You have the population, you have the average stay. What else? Could be a problem. So what about, let's say, seasonal effects? If you have winter and you have more flus than in the summer term. So here there's a number of critics summarized. First of all, we exclude that customer has the freedom of choice. Okay, so we know that some of the patients from North Rhine-Westphalia are coming to Karlsruhe to be treated, even if North Rhine-Westphalia might have enough beds. Okay, so they simply don't like it, what for reasons ever. So, but customer's choice might be absolutely independent of the number of beds. Okay, so this is not included in this formula because it simply says, okay, this hospital is built for the demand for North Rhine-Westphalia or Baden-Württemberg, something like this, and it assumes that this population and these patients are coming to this particular hospital. It could also happen that we are going to another hospital in another state, okay? So the population is not necessarily that is covered, right? So as we know, Karlsruhe treating many patients from Rhineland Pfalz, for instance, okay? Not included in this formula. As I just said, no consideration of seasonal variations or trends. Also, when we had the problem with the corona pandemic, they didn't change the number of beds, obviously, not on this short notice. Okay. Yeah, and no one knows exactly how they determine the utilization level. No, it's absolutely arbitrary. Okay, it's somehow coming from somewhere. It's not really justified. No consideration of parameter dynamics, so there's no time component, there's no, for instance, the demand volume could change over time because we get some kind of older population or some particular diseases because of climate change, something like this. Also the length of stay might change over time due to technology advances. It could happen that we need less time within the hospital. We can treat them more ambulatory so that they can leave on the same day. And this is also not included, some kind of trends and dynamics, okay? And sometimes experts are asked to get an alternative formula or an approach to determine beds. And what is needed is particular forecast methods. So what do we need in the future, and therefore how many beds do we need then for a particular specialty? So again, if we say we have an older population, they will have some kind of particular diseases, we need the beds in a particular ward within the hospital. Okay, this has to be taken into account. Then also expert interviews, what they think climate change might have an effect on particular diseases. Okay, then we have the consideration of economic efficiency, so we want to be as efficient as possible, so the processes within the hospital, not the treatment itself. And consideration of morbidity, so what kind of diseases we will get, some, let's say in springtime, during winter season, and so on. Okay. And that means that we have to come up with some kind of good estimate, some kind of good forecast on how many beds are needed. Okay, and we have to take into account the demography, of course, age, gender, risk, race, and so on. Then the decision of the patient to go to a certain hospital, for instance, Heidelberg could be an alternative for us. Morbidity, as I said, what types of illnesses can we expect in the future? But also medical advances, as I said, the length of stay could be shortened. We could have more ambulatory treatments instead of stationary, so that a patient don't have to stay overnight. We could have system changes that we have to take into account. So not only the length of stay, but also some kind of adoption to the DRG system. And with Lauterbach's new reform, it could we have to maybe adjust the hospital and the systems to the new reform. So let's see what will change in the future. And we also have to understand when to expect them. Not all changes will be on a long term. Not all changes will be continuously implemented. So sometimes we have to take the seasonal variations into account, and also the question how long they stay. Okay, so changes, for instance, due to reason given for the first time, so for demography, for instance, could be that we get this older population, we get particular diseases, they have to live with that, and we have to treat them, okay? And then also data on the length of stay distribution. For now, we only have the average length of stay, but we we don't consider some kind of standard deviation. Okay, so it could happen that on average the patients are staying for 5 days, but it could be plus minus 7 days. Okay, which is really significant in terms of how many beds are needed. Okay. So to get this kind of information on the parameters, we need some kind of forecasting methods. Basically, we consider 3 types of forecasting method. The judgmental methods, it's purely that we talk to experts and ask for their opinions, and then they tell us what they think will come or will be needed in the future. Then we have causal methods, simple statistical regression models to determine, for instance, the morbidities. So we estimate the population first with some kind of demographic characteristics, as I said, age, gender, race, for instance. And then based on this estimate, then we determine how many beds will be needed in the future. Okay, but we are not very interested in these approaches. We are rather interested in time series, so we are using historical data to predict then the demand volume for the next year. Okay. And if we already got a solution, so someone told us we decided to have a particular number of beds, then we can still evaluate how good or bad the decision was by using, for instance, analytical models purely based on queuing theory. So how long does, for instance, a patient has to wait for treatment? Either so he's or she is entering the hospital via the emergency department, and then going through diagnosis, maybe some kind of emergent surgery, and then till the patient's leaving again. Okay, so this is the entire queuing system. Or we can use also simulation techniques to evaluate how good or bad the decision was. Wasn't enough beds, or weren't there enough? And did we have to reject patients? Okay. Okay, so typical time series patterns, we have the constant level, okay, where we could use simple moving average or simple exponential smoothing. So the red ones is always that we want to look at this. So moving average simply means you take always the last 4 or 5 days, okay, to predict tomorrow's demand, and then tomorrow you use the last 5 days to predict the day after tomorrow, and so on. So what do you think is what is a very stable demand in healthcare? What do you think? Population, is it a stable one? Let's say, yeah, is population a stable demand? Who would say yes? Okay, and if I change the wording in is the population per year stable, would you then say yes? Okay, so I assume that there's rather no, so it's not stable. Population is not stable. Okay, why? What would you say? The population size from one year to another one is not stable. Why do you think that? So those who didn't raise their hand. So why do you think it's not a stable one? Okay, but you mix now the population with patients, right? So what if you say population? Do you assume there's a trend? So others who wouldn't say yes? Is population a stable demand per year? Yet not let's say not over the last 20 years, but per year. So is that who would say there's a trend involved? Seasonal effects? So we can assume that population is a pretty stable one. What about washing machines? Stable demand? Who would say yes? Okay. Who would say no? You have to decide. This is a binary question, right? Yes or no? So who would say no? This is not a constant demand. So you didn't raise your hand, so what would... You said yes. I'm sorry then for that. So what about you? Yes or no? Okay. It would help if you would raise your hand then. Yeah. Washing machine. If this is a stable demand for washing machine. Yeah, it's indeed stable because you don't buy every year except it breaks down or something like this. But what about vaccination programs? Who would say this is a stable demand? So if you get vaccination, so demand for vaccines, who would say it's stable? Okay. Okay, you would say no. Okay, why? Why do you think it's not stable? Yeah, the funny thing is that although with Corona and something like this, on average per year, the demand for vaccines is pretty stable, which is really could be not that intuitive, right? What about emergency services? Demand for emergent treatment. So the demand in an emergency department in a hospital. Would you say this is a stable demand? Who would say yes? Okay, who would say no? Okay, so the majority is for yes. Yeah, exactly. I said last time that this is the usual case actually, and on average, again, you have always to look at the average numbers. On average, it's indeed very stable. This is rather for let's say Germany, where we have some kind of natural disasters, hurricanes, tornadoes, flooding, and so on. That, on average, might not be the case, but here in Germany we don't have so many natural disasters. We have sometimes flooding, but this is not the usual case, right? And we also don't have so many... sorry for that. We don't have so many mass accident events because we have a secure infrastructure other than in other countries. Sorry. Okay, and then we have here linear trend. So what could be an example for linear trend, independent maybe from the hospital or healthcare setting? What kind of demand do you know which has a trend, either positive or negative? Just choose. Or I choose one of you. Yeah. Exactly, because they're getting older, right? And also because they get this fixed amount of money for these particular cases and it's profitable, the physicians are also pushing into this direction, saying, yeah, you definitely need a hip surgery. That's true, exactly. Someone else, some kind of example? Yeah. 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 Exactly. So we have, we could also have a negative trend if the IT and medical technologies are advanced ones and used. Then we also maybe don't need some kind of profitable surgeries because they have changed to some kind of ambulatory treatment. You had also an idea? Okay, so you think big. Okay, so the entire world, exactly. We are rather focusing in Germany, but you're absolutely right. Exactly. So, and here when we have a linear trend, when our data is saying, okay, we have some kind of certain data that has either positive or negative trend, then we would rather use linear regression or so-called Holt's method, which is double exponential smoothing. We will come to that in a moment. And then, of course, you have these seasonal effects. The Winters method, which is a triple exponential smoothing, when you try to catch up with the, let's say, flu within the winter term and so on. Okay. So when you look at time series notation, then we definitely need the time period. We have, let's say, 1, 2, whatever, hours, days, months, years. We have the demand values for this particular time period, and then what we want to forecast is y. So, and this is why t starts with the second, let's say, month or something like this. So we have the January demand, and we want to forecast the demand for February. Okay, so it starts with a second period. And then, of course, to evaluate how good we have been with forecasting, we have to determine the forecasting error, which is simply the demand for time t minus the predicted demand for the same period. Okay, and then we can evaluate this particular time series and our prediction by using the mean square error, which is simply to sum up all the squared errors, okay, and taking basically the average over the entire time period. What would you say? Why do we have to square the errors? Why not simply summing them up? Mm-hmm. Exactly. This is exactly the reason. So we don't want to cancel that they cancel out, because we could have negative errors, positive errors. And why squaring then? Why not say simply using the absolute values? Why? Yeah. Sorry, can you say it a little bit louder? Exactly. Exactly. So it's simply, as you explained, to weight the outliers more. Just a brief summarize your comments. Okay, exactly. So on the other hand, when we say we have, so let's go back. So the mean square error just said how bad or good was your forecast, and now we're coming to how to forecast that. So if we have constant demand, then we could use exponential smoothing, okay, which is called basically the exponential moving average, which considers all the historical demand, but in contrast to the simple moving average, we now weight the recent observations more than older ones. So as I said before, so moving average is simply using the last 5 days to forecast tomorrow's value, and exponential smoothing means you weight recent developments, recent demand more than past ones. So for instance, yesterday's demand should get more weight than the day before yesterday. Okay, so this is pretty simple, and you have this formula where you predict tomorrow's demand by multiplying alpha, the so-called smoothing factor, by the demand of today, plus 1 minus alpha multiplied by the forecast for today. Okay, so you forecasted, as let's say, today we have demand, the real demand of 30, but you forecasted for today a demand of 20, then you have an error of 10, which is here, and this is then weighted by the smoothing factor. Okay. Okay, and of course, the let's say if you want to predict tomorrow's, and you don't have any historical data, then tomorrow's prediction, tomorrow's demand is the same as today's demand. So this is simply a starting point. Okay. And then if you want to have some kind of, let's say, next week Monday, okay, then you can plug in this formula again and again in a recursive way. So this is basically what is shown here. Okay, so this is a recursive formula where you simply have a convex combination of alpha times and then d and 1 minus alpha, what you predicted basically for today, the y. Okay. And the smoothing factor alpha is simply the recursive use. That means that the weight is exponentially decreasing. Okay, same here. Okay. So today or yesterday's demand is more weighted than last week's demand, for instance. Okay. This is the basic idea of exponential smoothing, and the smoothing factor is simply to smooth out the variations of the demand. Okay, here we have an example with a smoothing factor of 30, so 0.3 basically, and we have the demand, let's say, for the last year, January, February, and so on till December. And now we want to know what is the demand for January next year. Okay. And as I said, so when you don't have historical data, you start simply with today's, or let's say January demand, okay, which is 60. So your prediction for February is the same as for January. And you can see here the actual demand, the real demand, which fluctuates. And then for the demand for March is predicted by simply using this recursive formula. So you have alpha multiplied by D2. So the demand for February is 959 plus 1 minus alpha, which is 0.7, multiplied by the prediction for February, which is 60. Okay, so nothing fancy. And you see here that when you use the moving average, this is the orange color, you can see that you have a more fluctuated version than the exponential smoothing, which is a very smooth, so the green one, which is a pretty smooth average. Okay. So you still have the fluctuations, but not that significant than the real demand. Okay. So you try to predict the January demand based on the entire last year, where the recent demand is more weighted than those of the last year, for instance. Okay, so February, March, and so on. And when we evaluate mean square error, we get 2.09. What would you say is a good one or not? If you see that the MSE here is 2, would you intuitively say it's good one, it's bad one? Yep. Mm-hmm. Exactly. So 0 would be perfect. That would mean we have absolutely perfect match. However, it's difficult. It depends. This is the perfect answer always. So it depends because it's an absolute value, and you definitely need some kind of comparison, right? So, but you're absolutely right. So here another example for the April demand. Okay, simply plugging in the numbers. Okay. And the question is now, when we say that 2 is good or bad, or depends relatively to other measures, how to decrease it. So how to get it to, how to improve the error. What can we do? When you look at this formula, what can you do to improve and decrease the error, the mean squared error? What could you use? What can you change, basically, to improve the forecasting? Yeah. The smoothing factor, exactly. So we can play around with alpha, right? As a decision maker, we can set alpha. So the question is how to find the best alpha in order to decrease the error. Okay, in order to have these small mean square errors. Okay, so what is not suggested, let's say, if you get new data, okay, if you don't have only 1 year, but if you have the last 5 years, you always have to look at your data, and then based on this data you have available, you have to adjust alpha. So you cannot simply at the beginning of your planning period, you simply cannot say, okay, we choose the alpha of 0.3 and that's it for the next 10 years. Okay, as soon as new data is available, you have to adjust alpha. Okay, and this calibration can be done automatically. Okay, so you don't have to do it by hand. Okay, so which is typically the case is that we choose alpha between 0.01 and 0.3. These are typical values, and of course if we decrease alpha, if we go rather to this 0.01, of course then we can respond only slowly to changes. So if we have a very stable demand, then of course we don't need a high alpha. Okay, and this means in the same time that older data is relatively weighted more than recent ones. However, never as much as the recent ones. Okay, even if you choose an alpha of 0.7 or 0.8, because of this recursive relation, you will always weight the recent more than older ones. It's only, this is the key word here, relatively. Okay, strong, the weight. Okay, the other way around, if we choose rather, if we increase alpha, then of course we can adjust our forecast based on demand changes. So if the demand fluctuates pretty strongly, and then we want to know, we would like to have a forecast that is close to the last one, then we can choose a higher alpha. Okay. However, information of historical data is then lost pretty easy and pretty fast. Okay. It depends what we want. Okay. It depends on the data we have. Okay, if we play around with alpha for this particular example, then you can see that if we would choose alpha of 0.2, then we could decrease our mean squared error, and we would have a 2.04. So this is the minimum. Okay, so that would be optimal in our case. Okay, questions so far concerning the exponential smoothing? Okay, then Holt's method, if you have a trend, then you can use the double exponential smoothing, so which is pretty similar to the exponential smoothing, but we have not only smoothing factor, alpha, which gives us the average demand, but also the slope, so how steep is the slope, how steep is the trend we are observing. So the forecast, we need this slope to also consider the trend, and that we can have a future demand prediction that also covers the trend within the data. Okay, basically very similar. So we have this let's say tomorrow's, if h is 1, so we have tomorrow's prediction is the average demand plus the trend, okay, so the slope within the data. Okay, and then the average demand is very similar to the previous one, so we have the smoothing factor multiplied by the current demand plus 1 minus alpha multiplied by the average demand plus the trend that is involved. Okay, and again for A2 we use the current demand, and for the slope here we need the beta for the slope multiplied by the basically the deviation from the average demand plus 1 minus beta multiplied what was predicted yesterday for the slope. Okay. And for the second period for the B for the slope, we simply use today's demand minus yesterday's demand. Okay, and both components are between 0 and 1. Okay, so as I said, A is simply the combination of the new observation and the preceding forecast, identical basically to the simple exponential smoothing which we just saw. And B is the combination of the difference between the new constant level and the previous one. This is basically this one, and the preceding estimator for the trend. So this is what we have estimated, okay, and this is what is the actual deviation. Okay. Here again, example as before, we have the last year, and we know that the smoothing factor is 0.3 and beta for the slope is 0.4. Okay, and the first A and the first B is using the demand. So the average demand A for February is the same as for the actual demand, which is 58 here, and B, the trend, is 58 minus 59. So we have minus 1, so this seems to be a negative trend, and therefore when we try to determine and predict the demand for March, that would mean this is the February average demand plus minus 1, because the trend is minus 1, and we predict a demand for March which is 57. Okay. Okay, the same for demand for April. Okay, simply plugging in. So we have still a negative trend, but it's not anymore minus 1, but it's minus 0.28, so it's not that steep. So, and we get at the end of the day, when we plug in all the numbers, we have now, after that, we have for the next year, January, a demand prediction of 79.4, okay, which is close to the December demand, but is pretty far away from the January demand last year. Okay, and we have then mean squared error of 13.8. What do you think? Why is here the mean squared error worse than when we use the exponential smoothing? There we had the 2.09. Here we have, when we use a double exponential smoothing, we have a prediction that is worse from the qualitative perspective. Okay. So we get a forecast that is not as good as the exponential smoothing method. Why do you think is that? Mm-hmm. Yeah, exactly. But why is this the case? We use a double exponential smoothing. We put a trend in it. When we look at this example, Okay, is there a trend involved here? So if you look at the blue demand line, do we have a trend here? Exactly, no. There's no trend. Therefore, if we put in an artificial trend inside and we use the double smoothing method, it won't help us. So there is no trend. This is why it's so important to look at your data first, to understand the data you have before you start using some kind of forecasting method. Okay, so your forecasting method should be appropriate for your historical data you have. Okay, don't think that if you use, let's say, if you plug in trend and seasonal effects and whatever, but your data doesn't give you some kind of indication to use this, then you will end up with a worse forecasting than simply using exponential smoothing method. Okay, sometimes it's better to use a simple one, but it better fitted to your data than some kind of fancy forecasting methods that are not useful. Yeah. Here, actually it should be very similar to the one before. Yeah, there's a bit trend involved, exactly. Yeah. Yeah, definitely. You're absolutely right. So the other way around, if you have a trend and you use the exponential smoothing method, then you will end up with a worse MSE. That's absolutely true. Yeah, exactly. So this is why it's so important to understand the data you have and then choose the right forecasting method. Absolutely right. It's because the problem is if you smoothing it out, right? So you have a trend, but you still try to smooth it, you will end up with errors. So you have deviations from the real, because every time you forecast, the peaks are there, but they are some kind of delayed. No? And this is why the problem is that you have these deviations from the real curve, let's say. And then naturally you will end up with a higher MSE. Yeah. Okay. Okay, so that means we need a method, or we have to rethink how to determine the number of beds that are needed. So either we use the forecasting methods, therefore we can predict the average demand, patient demand, per year, month, day, whatever, and then going to the hospital and saying you need more beds, less beds, whatever. Okay. The problem is that you have this high level of uncertainty which is involved every time. So you won't be able, never, and this is why you always will have some kind of error, some kind of prediction error. You won't be able to predict the exact number of patients, and therefore you won't predict the exact number of beds needed in a hospital. Okay, on average, yeah, you can do that, but there will be always deviations from the real demand realization. And here, to evaluate a decision, so if the decision on beds are already done, we can use simulation to evaluate that. So we can, virtually at least, test different capacity levels. What if, so simulations are basically used to answer the question, what if, okay? So we don't want to optimize things, but we want to understand what if we have more beds? What if we would have less beds? So what are the consequences? So we play around with different capacity levels to understand the consequences for the hospital and also for the patients. And with simulation, and this is the nice thing about it, we can introduce stochastic uncertain demand patterns. So demand is coming absolutely on a stochastic level, maybe in the morning, maybe on Wednesdays, whatever, like we want to. And we can also play around with the length of stay distribution. It could be that they have to stay longer, or the uncertainty is that we have a distribution that we could have plus minus a higher deviation from the standard length of stay. And we can also measure the utilization rate and the number of patients that have to be rejected, but always on a rather longer time period. So, okay, this is what you want to have, because often you have these, but when you use forecasting methods, you often assume that they are independent, the variables are independent. But the problem is that in real life, they are, of course, dependent on each other. And this is why it's so nice to use then simulation to play around with demand, uncertain length of stay, and so on, different capacity levels. So one such simulation was carried out by Professor Nichols' team, and they simulated some kind of, here looks like a normal distribution of arrivals of patients per day. Okay, so they are coming into the hospital, and then it's decided if no beds are available anymore, then these patients have to be rejected, so they leave the hospital without being treated. Or if beds are available, then they are admitted to the hospital, and then they stay again based on some kind of distribution. So you can see here that on average, so the most patients are staying 2-3 days, but it could happen that they stay even double as long, 6-7 days, or they could even leave on the same day, but the probability is very low. Okay, so most of the patients are somewhere here. Okay, and then after the length of stay, they are leaving the hospital anymore. And what was that they found out that the utilization rate of beds is about 86%, which means that 14% of beds, let's say out of 100 beds, 14 beds are on average empty. Okay, and what they have done was that they played around with beds. So if they increased the number of beds from 70 to 110, and they looked at the number of rejected patients. Yep. You mean this one? Yeah, this is when they enter the hospital and they don't need to be admitted because they have some kind of nose problem, whatever, or earring. They just get the medication and can leave on the same day. So this is why they have also 0 length of stay. If they are not admitted to the hospital and they don't need a bed, basically. Yeah, exactly. Okay, so they played around and they determined the number of rejected patients, and it's clear the more beds you have, the less patients you have to reject. But the problem is, at the same time, the more beds you have, the less utilization rate you get. So you have, on average, many beds that are empty. And if you are talking with physicians, they don't understand that. How can that be that we have more beds but have a low utilization rate? Okay, so the problem is that you have, these numbers are on average. Okay, so it could happen, so that the question is, why do you have to reject patients? Still, you have to reject 6 patients, although only 72% of beds are occupied. Okay. As I said, this is because of the average. So on a daily basis, it could happen that on a particular day, all beds are occupied, you have to reject the patient, but on average, over the last year, the utilization rate was 72%. Okay, and this is what is pretty difficult to understand. Not all beds are occupied, but still you have to reject patients. And of course you have this kind of trade-off between you would like, or the hospital would like to have a high utilization rate. They would like to have beds occupied, and on the other hand, we want to have as a low number of rejection. Of course, we would like to treat every one of them. Okay, and here's an example. So if you would like, or if the hospital would like to maximize profit, then of course it's always this profit for treating patients, so the more the better. But you have resource costs. Beds are very expensive, and this is why we saw last week the statistics where we have this also the decrease in beds. They are very expensive, and they have to be covered by a nurse. So for instance, here's a joke basically. The nurse-patient ratio is simply how many patients can one nurse cover, and it depends on the specialty, of course, but on average, let's say, one nurse can treat 3 patients. And here the joke is, if we would apply this ratio also to beds, so how many patients can one bed occupy, then we would be more efficient, let's say, if we could put more patients in one bed than only one. Okay. But you always have this kind of problem between costs, high utilization, and also rejecting the patient. Okay. And again, the Hill-Burton formula, which we saw at the beginning, this is not covered by this formula. Okay. This is another critique of the very old one formula that is still used in Germany. Okay. Okay, here also there was a praxis seminar carried out by Professor Nickel, and the students looked at different specialties, A, B, C, whatever, heart, cardiological, maybe heart surgery department, and so on and so on. So different specialties, and they wanted to determine the minimum number of beds using a simulation technique, and they looked at 2 different variants. So variant 1, or A, is time out of function was included, meaning that if a patient is coming to a hospital and has to wait more than half a day, they are rejected and leaving the hospital without being treated. And variant B is there's no time function included, so everyone is at some point treated. And you can see that although we don't have a time out function in B, we have a higher number of beds that are needed, but a lower utilization rate. Okay. Then in variant A, where you are rather rejecting the patient if the timeout is coming, and you need less beds. Okay, so here we are done with the hospitals in detail lecture. If you don't have any questions so far. Last week I uploaded the exercise 2, and I recommend it. I mean, you could try to solve it by your own, obviously, but I would suggest now, after the formulas were discussed, you can try to solve the exercise 2, which is uploaded, and also doing this poll about the Hill-Burton formula, why it could be criticized and so on, what is not included. Okay. And on Thursday I will upload it again, the solution. Okay, then let's change and start with that one. The appointment planning. Okay, so this will be covered in several lectures. We will start today with matching supply and demand. So what is the basic problem when trying to get an appointment from a patient perspective, but also from a hospital or physician perspective. what kind of appointment policies do we have to consider also later on for the optimization models. And I think we can end with the appointment planning models next week. Maybe we'll start with a case study. Let's see how much time we have. Okay, so the principal problem also especially in logistics and other industries, so this is not healthcare specific, is the problem of matching supply with demand. This is always a problem. So we have on one hand the patient demand, demand for medical treatment, on the other hand we have the supply of medical treatments, and now how to match this. And the important note, which seems maybe ridiculous, but the provider and the patient have to be at the same time, at the same location. So if we look at the German healthcare system, of course, you could have capacity left in Hamburg, but if you are living in Baden-Württemberg and Karlsruhe, that doesn't help you that much. Okay, and this is why it's so difficult to match both the supply and the demand side at the same time, at the same place. Okay. Nowadays, we also try to overcome this challenge by using telemedicine. So if you can consult a doctor via your internet and using Zoom, Teams, or whatever, so that the consultation is provided remotely. Okay, so this is nowadays. But in general, the traditional, you have to come to a physician or to a hospital to be treated. If you look at the supply side, the hospitals or the physicians, then of course it's characterized by, do we have enough doctors, do we have enough nurses, and the right doctors and the right nurses with the right skills. So not all doctors can treat all illnesses. We need the medical devices, MRI for corona, we needed oxygen masks and so on. We need the examination rooms or the surgical rooms, so you cannot do an operation on the floor. You need a kind of room that is safe, has all the equipment available, and you also need waiting rooms, so no one is or can wait outside the hospital. I mean, you can. It's also not in Germany, but especially in Italy during corona times, the patients were dying outside the hospitals, basically in their cars, okay, literally in their cars. So you need also rooms and space. On the other hand, if you look at the demand side, then this can be characterized by arrival patterns. Okay, so the distribution, often patients are coming either in the morning or shortly before lunchtime or after their working times and so on. This has to be taken into account, and we have to differentiate the priorities. So it could be an urgent patient or non-urgent or even an emergency one who has to be treated immediately. And then what kind of resources does this patient need? Only a doctor or a nurse or some kind of medical device, MRT, MRI, I would say in English, and or a CT scanner, whatever. Then the time, the resources or the service duration. So deterministic, is it clear that the patient needs 15 minutes of treatment time, or is it even longer? And of course, patient could have a preference. If he, she, they would like to see a particular doctor, or if they would like to come in the evening or in the morning or whatever. Okay. And okay, the sketch is not covered by our optimization model, but what could be also an additional problem is that not all are communicating in the same language. Okay, so for the doctors particularly, it's difficult, might be difficult, even if they have the same illness, but if they articulate it differently, it could pose a problem and therefore increase, for instance, the service time, okay, or the treatment time. And then we are again in this stochastic version. And if we see the supply side, then the demand side, and now we have to plan, because we would like to match the supply and the demand side. So we want to match that patient and provider time. Okay, and the objective is that we want to have possible actions of the provider to cope with a given demand. So what we don't want, or what the physician doesn't want, is that they have times where patients are waiting because we have an overload, we have a demand peak, and then we have idle times where there are no patients and the doctor and the physician are sitting around without doing anything. Okay, so this is what we don't want. Have on one hand overtime, waiting times for the patients, and on the other hand having idle times. It's the same for car production assembly lines. They don't want to have any kind of idle times because it's inefficient. Okay. So the task for the provider is they have to decide, do we accept or do we reject a patient? This is the first one. And if we accept them, then we have to understand when to treat this patient. So today or tomorrow or whatever. And we also have to understand if it's a walk-in. So if they don't have an appointment, they're simply coming in and saying we need an urgent treatment or not. Or if we need an appointment in the future, how far in the future. And of course, after making these appointments, we or the provider has to ensure that the patient is treatment in this planned time slot. On the other hand, what is the objectives of the patients? Of course, the patient would like to have access to care, right? They don't want also to wait too long. And sometimes, especially if it's not urgent, then they would like to have an appointment when it suits them. Okay, after work or during lunchtime or whatever. Okay. But the provider's objective is, of course, to have on one hand high utilization rate and at the same time low idle time, so that we have a really smooth production process, let's say. So they also don't want to work overtime, and at the same time, and I think this is rather theory, they would like to satisfy patients' objectives if possible. And as I said, I've never experienced that, but in theory, I think they want to satisfy patient demand. Okay, but the problem is we have here conflicting objectives. If I want to treat everyone, I need overcapacity, and if I use given capacities, I might have to reject patients. Okay, so not all the objectives can be combined in a smooth way, at least. Okay, so what we know is that patients have to wait, and we have to differentiate. First of all, the indirect waiting time. I don't know if you experience that. I guess so. So if you call either a physician or hospital to get an appointment, sometimes if it's a specialist, you need to wait for months. And sometimes, especially if it's urgent, then they say, okay, come in the afternoon or something like this. So these are the indirect waiting time. So the time between your calling for an appointment and getting this actual appointment. Okay. So the problem is if you have waiting for months, especially if you have a heart disease, some kind of heart disease, and you have to wait for months to see the specialist, then your symptoms, your health status can deteriorate significantly. And of course, the patient is dissatisfied, but this is not really looked by the physician. But this is a personal note. And then you have direct waiting times. So this is the waiting times when your actual starting time of your appointment minus the maximum of either the planned starting time or the arrival time of the patient. Okay, and again, if these direct waiting times are long, then the patient is unsatisfied. So if maybe it helps when you have this kind of figure. So you have an appointment request where you call the doctor, then you have maybe wait for days, maybe months, And then you have the arrival time at a hospital, let's say, or the physician. You have to register, you have to show your card and so on. And then you either have to wait because you are too early, or you have to wait because the room is not free, although you have your scheduled appointment time. Okay, so this is the internal waiting time. So actually your appointment has already started, but you cannot be seen by the doctor because he's occupied. Okay, and then when you come into this state of treatment, then your starting time or the time has started. Okay, so the longer you have to wait here, the longer you have to wait here, the worse or the more unsatisfied the patient is. Okay. And what we try, of course, is to reduce the internal waiting times and, of course, to reduce the indirect waiting times. When you look at the statistics for practices, and also not for hospitals, then you see here for the indirect waiting time. So when you're calling and you're getting the appointment, you can see that you have no waiting times. This is this is most often the case. Okay, but of course you have to understand if this is a specialist or not. If it's a general GP, then of course you don't have to wait that long because you have actual symptoms and you can come often the same day or maybe tomorrow. So this is the highest proportion, or you are rejected at all. That could also be, so these are the majority. So if you call a doctor and they have a panel that is fixed, then they say we don't take any new patients anymore. Okay, and then you are instantly rejected. And then you have the waiting times, which is the direct waiting time. So if you have already an appointment, you are there and you are waiting for your treatment and seeing the doctor, then the majority is to wait up to 15 minutes. So I've never experienced that, by the way. Never experienced that. I always wait half an hour, 1 hour. So this is the general waiting times. I don't know in our case, but I've never experienced that. And then I saw that the statistic is from 2015, and I thought, okay, let's change it, because this has definitely changed towards this 2 hour rather than 15 minutes. And then I had a look at the statistic and found one for 2019. It's really similar to this one. So I don't know if the statistics are manipulated or is it really a subjective opinion of me personally. I don't know. But according to statistics and the newest ones, the majority has to wait up to 15 minutes. Never experienced that. But okay, maybe you confirm that. Okay, so by the way, who experienced up to 15 minutes waiting time? Longer than that? Yeah. Okay. So I think the statistics are manipulated. On a personal note. Okay, and then waiting times of patients per country, and you can see that Germany actually they are the best in waiting time because waiting less than 1 month, and you see in Canada it's really, really bad. You have to understand that these are the practice, not the hospitals. If we would look at the hospitals, then you would see that UK and I think Malta is really bad. They have to wait months for standard, let's say, hip surgeries. And I know that some from UK are coming to Germany to get their hip surgery done, and they're paying, of course, privately. Here, they are not covered by the insurance companies in Germany, of course, because we have really not a lot of not that high waiting time to get to a physician, at least. Okay, so these are not hospitals. Okay, for hospitals is worse. Okay. And then the other way around, that patients have to wait longer than 2 months. Okay, so before it was less than 1 month, now longer than 2 months. And you can see here again, Canada is they have to wait the most, and Germany again is on the second place. So we are not that bad. Okay, and then often you have the feeling that privately insured patients don't have to wait that much than publicly insured, and you're right. So privately insured, they don't have to wait at all, or up to 50 minutes. And if you go to this 2 hours or more than 1 hour, then you see that the public insured patient have to wait longer than the private ones. Okay, so at least this statistic is true. Okay, so from the physician perspective, what we want to reduce is to balance is the idle time versus overtime. Okay, as I said, idle time is where the doctor or the capacity is available, but there's no patient. Okay, during working hours. On the other hand, often doctors or physicians have to work overtime because patients are coming shortly before the opening hours are closing. And you can see here, so they start working, then of course in the morning many patients are coming, then about 10 o'clock no one is coming, so there might be no patients, we have idle time, and then again shortly before the end of the working day, then patients are coming again and the physician have to work overtime. And what we want to do is basically, if we could cut off a little bit of overtime and putting into, you cannot see that, sorry. So if we cut a bit of overtime and we plug it into an idle time, so we cover that one, we fill in the idle time, then we have to work less in the evening, let's say. And this is what we want to try, okay? Less idle time, less overtime, okay? To smoothen the demand uncertainty out, or the demand fluctuations out. So this is why we try to regulate supply and demand. So on one hand, we can regulate supply. So before thinking of how many working hours we want to provide, we definitely have to estimate the future demand. So again, using some kind of forecasting method, and then decide on the number and working hours of resources. This is basically a strategic decision, okay? On one hand, and the tactical decision on the other hand. This will be covered then later. And also later we want to try to understand how to adjust our supply side in order to face fluctuating demand, okay? For instance, how to deal with seasonal effects during winter, as an example. On the other hand, we can regulate demand. So of course we have this fluctuating demand, and it's not possible to offer, in general at least, not to offer enough supply to fill all the demand. Okay, so at one point we have to reject or postpone demand in any case. And for example, in primary care, the doctor often has a panel, as I said, and if you call and they say, we have already a panel, we don't treat any new patient, then this is the physician's choice, okay? You cannot do anything about that. So you cannot force the physician to take you, and no one can do that. So this is their choice, okay? So this is some kind of panel management also. We could also consider whom to take and whom to reject, okay? With respect to let's say, profit. Okay, and here we come to appointment policies. So how to make appointments, how to smoothen the fluctuation in demand. So appointments are nothing else than points in time or some kind of time slots assigned to patients, such that treatment should begin at the point in time or take place in the time slot. So we don't want to have overtime, okay? And appointments, the objective of getting an appointment and providing some appointment is to smooth out our demand fluctuations, okay? Of course, for non-urgent treatments. If we have an emergency, we have to treat them. So the basic idea is we have some kind of fluctuating demand, which might be significantly fluctuating. Then we assign appointments and build a plan. So we say, okay, you are coming tomorrow at 5, you are coming tomorrow at 10. So we have then a plan so that we have a deterministic demand in the end. The problem is, of course, that if we give these kind of appointments, patients might experience indirect waiting times, because we know for the next month the time slots are absolutely full. Then they have to wait. We cannot schedule urgent emergency demands, obviously, and we could have walk-ins. So often patients are simply coming into our practice and say, I won't leave, I want to be treated today. And maybe they have to wait, but they will be treated. And this is a very big problem. Patients may not show up to their appointment. Okay, we have the problem of no-shows. And of course, they could cancel their appointment, but at such a short notice that we cannot assign anyone else anymore. And of course, also patients could be unpunctual. Duration of appointment could be stochastic, so someone needs for the same treatment much longer than another one. Okay. And our research questions now, given the setting, how can appointments be used to match supply and demand efficiently? So this is what we try to understand and what we try to answer. So we could have a primary care practice that we consider. We could have an outpatient clinic, meaning that their patients are coming in to be treated at the same day and leave at the same day. No beds are occupied, for instance. Then diagnostic devices are needed for in and out patients. We have to deal with that. We have to plan for that. And also operating theater. When to plan which surgery, using some kind of estimating times. Often surgeries are longer than expected, and then the entire schedule afterwards is then delayed. But this will be then treated in a later lecture, operating room planning. And basically we have 2 appointment policies. So first of all, the traditional, which we all know, we are calling and we are booking appointment in advance. But nowadays we have some kind of open access and advanced access policy. For instance, Netherlands are testing it. Patients are calling in the morning, and either they are getting an appointment today or not at all, or they are rejected. That means they are calling tomorrow again and trying to get an appointment for the next day. Okay, and of course we have these kind of mixed modified policies as well. So, for instance, carve-out policy. So this is the traditional policy where you call and try to get an appointment, but some capacities are saved for urgent cases, for instance, so that we try to treat the patient as planned. Or we can also have an open access, but with a 2-day horizon instead of only today. So they are calling, either getting an appointment today or they can come tomorrow. Why should we look at alternatives instead of our traditional ways of policy making? So a lot of medical practices are confronted with absolutely full schedules every day and long waiting times. The question is, so if we want to, if we use the carve-out method or policy, then the question is, of course, how much capacity should be resolved? What is optimal? Okay, and the consequences are, with the traditional ones, that we don't have time to treat urgent patients. Maybe at the same day, we have long indirect waiting times, so patients have to wait long for getting an appointment, and we have high no-show rates. So studies have shown that, especially if you get an appointment in the future, the probability that they won't show up is pretty high, because sometimes if you don't get an appointment, you call several physicians and try to get several appointments, and you don't call again to cancel the other appointment. So this is often not done. So they simply don't come at all, okay? And therefore we have lower throughput. We cannot treat as many patients as planned, and of course less money then as a consequences. Okay, and therefore we could reserve some capacity for urgent patients. And open access, where you call in the morning and you get either today or tomorrow an appointment, they try to treat everyone independently, independently of urgency, for instance. So the motto is do today's work today. So that means, as a consequence, we have very low indirect waiting times. So they are coming today or tomorrow, okay? And of course, also as a consequence, low no-show rates. So if they're calling and asking for coming today, the probability is pretty high that they will come. And the drawback, of course, so what is definitely certain is that no plan works, right? So we have the daily demand that varies, that fluctuates, and sometimes there are less patients than time slots available, or the other way around, sometimes doctors have to work overtime or to reject patient requests. Okay, and then a simple comparison at the end of this. The first two, so access to care and consideration of time preference, of course, this is more relevant for patients. And the last two, so low variability of daily demand and low proportion of no-shows, this is relevant for doctors or physicians, okay? And what we have, patients would, of course, want timely access, obviously, okay? So in general, this should be easier in the open access. They're calling and they're coming, so they don't have really waiting times and can be treated on the same day. This is not the case for the traditional ones. On the other hand, patients with non-urgent problems, they often like to plan in advance, for instance, during lunchtimes or after work. This is better in the traditional policy because you can plan ahead. This is not possible in the open access version. And on the other hand, as the doctor likes to be fully booked in the traditional policy, the doctor knows, of course, in advance which patients are going to come and when. Okay, so we are not considering for the moment no-shows. Whereas in the open access policy here, the doctor has almost no control, okay, over the daily demand. Okay, and then obviously in the traditional one we have a high number of no-shows because the reason is if they booked several appointments or this is so long in advance that something happens and they simply don't show up. This is not the case in the open access policy. Okay, questions for the last minutes? Okay, then I think this is the last slide. Simply walk in. I just briefly, sometimes either the physicians or the hospitals don't want to have an appointment, then patients can simply come in. These are so-called walk-in hospitals or clinics. Sometimes they simply don't want to. And a service provider not assigning appointments operates under this walk-in policy. And sometimes we have also to deal with this high fluctuation, high uncertainty, and how to optimize this, even if they have a walk-in policy involved. Okay, and with this, I would like to thank you for your attention and see you, some of you, next Monday, otherwise see you next Tuesday. Thank you for your attention. Bye.